Awesome. So, welcome everyone. It's good to have everybody here. Today we're going to be talking about OCD treatments, and I'm specifically going to be focused on two of the sort of frontline recommended treatments for OCD, and then we'll also spend some time talking a little bit about other sources of support that can be helpful. But before we get started, I did just want to introduce myself and our lab and talk a little bit about what we do here. I know Carolyn had provided a little bit of an introduction, but my name is Emily Wilton. I am a postdoctoral fellow at the University of Minnesota. And here at the university, I am part of the Minnesota Tic and Compulsivity Lab, which is led by Dr. Christine Conalia, whose picture you see here in the upper left of the screen. And our lab's research is really focused on tic disorders and Tourette syndrome and OCD and disorders kind of along this spectrum of compulsivity. And so we have several ongoing studies that really aim to develop new and improved treatments for these conditions. And I'll talk about one in specific at the end of our talk today that's more focused on obsessive compulsive disorder, which is obviously relevant to what we'll be talking about today. Okay, so like I said, I'll start with some background about OCD and its symptoms, spend the majority of time talking about frontline treatments, and then end by discussing some resources for additional sources of support that can be helpful for both people with OCD and then also family members or people supporting people with symptoms. Okay, so just to start off, obsessive compulsive disorder is defined by the presence of both obsessions and compulsions. Obsessions are these persistently recurring thoughts, impulses, or images that are intrusive, inappropriate, or distressing. And as you can imagine, these obsessions make anxiety increase and are really uncomfortable and anxiety provoking. And then oftentimes obsessions are followed by compulsions, which are these repetitive behaviors or mental acts that a person feels driven to perform in order to reduce distress or to prevent a dreaded outcome or something bad from happening. And engagement in compulsions often decreases anxiety. It sort of alleviates those feelings or thoughts that came from the obsession. Researchers think that about 1 to 3% of people have a diagnosis of OCD, although that's probably an underestimate, just given the fact that OCD can be kind of hard to identify, can look really different in different people, and is sometimes not talked about. And so that 1 to 3% is probably an underestimate. The other important thing to know about OCD is that symptoms do wax and wane over time. And so it's really, really common for people to have periods of really high symptoms where there's lots of obsessions, lots of compulsions, and symptoms are sort of more intense, and then some periods where symptoms might be a little bit lower or less frequent. Lots of times these high periods of symptoms might be during times of stress or big transitions as well. And with that sort of fluctuating course, symptoms also can change over time. And so it's also common to have somebody that maybe had a specific obsession or compulsion maybe earlier in life that's no longer present or has been replaced by another. And so kind of both of those things can make identifying OCD really, really tricky. And okay, we'll move on. The other thing I just like to mention is that OCD lots of times kind of goes along with other disorders. So some people just have OCD, but it's also really common for people to have multiple symptoms. And so like ADHD, tic and Tourette disorders, and other anxiety disorders are also really common and kind of go along with OCD. All right, so I'm going to talk a little bit about some common obsessions and common compulsions that we see a lot. Um, and I want to just preface by saying that every person's experience with OCD is really, really different. And OCD is something that, the symptoms vary really widely. And so it's somebody with OCD might have every single one of these things on the screen, might have just some of them, might have none of them, but everybody's experience is really, really different. And so I'm just going to talk sort of about general symptoms that we commonly see. And so some common obsessions include contamination obsessions. So this would be like a fear of dirt, germs, or illness. Some safety related obsessions, so like fear of personal safety, or fear for, in kids especially, safety of parents or loved ones. Doubt is a big theme of OCD, and so this might look like doubting, that the door is locked, or that the stove is turned off, or that homework is completed. Unwanted, taboo, or inappropriate thoughts, aggressive thoughts, and then these feelings of things not being just right or feeling incomplete. And so that one, there might not be a lot of words to describe that, but it's just sort of a feeling that something's not right or something just doesn't feel right. Okay, and then common compulsions include washing, touching, checking, counting, repeating, some mental compulsions, arranging, telling or confessing, and reassurance seeking, as well as sort of maintaining some really strict routines and then avoidance. Um, as with obsessions, every person's experience is really different. The other thing is that a lot of the compulsions listed here may not be super obvious to people outside of the person experiencing it. And so some of these might be very easy to observe, like hand washing, you would be able to see that. But a lot of compulsions also are just happening sort of in the brain, or it's a thought process. And so for those things, that can be really hard for other people to see that and to notice that. And can look like other things. So sometimes that might look like somebody's really distracted or somebody's just not paying attention or listening, when really there's a lot going on inside that person's head. Okay. All right, so I'm gonna kind of move on to treatments here. Okay, so I'm going to go back one really quick. So I'm going to be talking about two frontline treatments that are recommended for treating OCD in both adults and in children. And the two things I'll talk about today are medication management and then therapy called exposure and response prevention. And because of my background in psychology and what we do in our lab, I'm going to be really mainly focused on the behavioral intervention or the exposure and response prevention today. But I'm going to begin by touching on medication, since that is one of the recommended interventions. Okay, so when it comes to treating OCD, researchers have really looked at what interventions or treatments work well for most people with symptoms. And so the information that I have on this slide is from a study that looked at the effectiveness of exposure and response prevention, the effectiveness of a medication, and then the combination of the two in reducing OCD symptoms in children. And what they found was that separately, both the medication and the behavioral intervention were about equally effective in treating symptoms of OCD. So you can see on the screen that is the little triangle and the circle on the graph. So they performed about equally well in this sample at reducing those symptoms of OCD. And the really important thing is that the combination of the two had the biggest reduction of OCD symptoms, or in this case, the best outcomes. And that's the square at the bottom of this graph. And so really the takeaway here is that both medication and behavioral treatment are effective and recommended as treatments for OCD. And medication and behavioral intervention together demonstrated the best outcomes. Um, just to note, the medication that they used in this study, and a medication that's often used to treat OCD is from a class of medications called serotonin reuptake inhibitors. And so that is a medication that oftentimes is used to treat OCD. There's lots of different medications that can be used. And so if there are, and again, every person's experience is different. And so if there are questions about that, that would be a good thing to talk, specific questions to talk to your doctor about. Okay, so I'm going to transition into talking a little bit more about behavioral treatments now. So exposure and response prevention is a frontline treatment for OCD. It's considered to be kind of the gold standard behavioral treatment, and it falls under this broader umbrella of cognitive behavioral therapy. So cognitive behavioral therapy is really focused on noticing, identifying, and challenging thoughts and modifying behaviors. And exposure with response prevention is a specific form of cognitive behavioral therapy that is used to treat OCD. So we're going to talk a little bit more about how exposure and response prevention works, and then actually what it looks like in practice. Okay, so in order to sort of get into how ERP works, I'm going to start by talking about this cycle of OCD. And so this is a cycle, again, that researchers really think is what sort of maintains or keeps OCD going over time. And so this cycle starts with an obsession. So again, this thought or image that's intrusive, upsetting, and distressing. And so when that obsession comes up, it leads to, again, this negative, bad, uncomfortable feeling. Could be anxiety, could be distress, disgust, or feelings of incompleteness. In order to sort of reduce or get rid of that bad feeling, the compulsion comes next. And so again, this could be a ritual, could be avoidance, so not doing things that trigger that obsession, or it could be escape, sort of removing yourself from the situation completely. And then now that the compulsion has been completed, that obsession is sort of has kind of gone away, and people experience relief in the short term and feel a little bit better. And we know that this is a cycle, and so the cycle will repeat the next time somebody has another obsession or comes into contact with something that triggers an obsession. And so the example here on the screen is for a contamination-related obsession. And so, for example, if somebody touched something that they believe to be contaminated, this obsession might come up that, my hands are contaminated, or I might become sick because my hands are contaminated. And so that, you can imagine, might lead to anxiety, distress, maybe disgust. And so the compulsion here, a person might engage in some hand washing maybe. And so the person washes their hands and then they feel a little bit better because that bad feeling has gone away and it's sort of been relieved by the compulsion. And the next time that person feels contaminated, the cycle will repeat. And so in kind of this cycle, the brain learns that in order to feel okay, the hand washing is required. And so exposure and response prevention works by breaking this cycle of OCD. And the way that it does this is by gradually facing situations that bring up these feelings of nervousness and discomfort, and then sort of letting those feelings be there and experiencing them without engaging in any compulsions. And so this sort of idea of doing things that make you feel a little bit nervous or kind of out of your comfort zone happens all the time outside of OCD treatment in daily life. So for everybody, if you think about something, that maybe you tried for the first time that felt really scary or anxiety provoking, that maybe isn't anymore now that you've practiced or had repeated experiences with that thing. So maybe the process of like learning to ride a bike for the first time or driving a car, or public speaking. So, the first time you do any of those things, it might feel really scary. You might feel nervous. And with repeated practice, the anxiety usually shifts the more that you do that thing, and sort of decreases over time. And so that same process that people experience in daily life, we also kind of use in OCD treatment. Okay, so I just wanted to talk a little bit about some terms that we'll talk about a little bit throughout the session today, that I want to make sure that we're all on the same page. So exposure, the term exposure, which I've already used, is gradually doing activities to bring up feelings of anxiety or discomfort. And then response prevention, the piece of it is to resist doing those compulsions or avoidance. And then habituation is another term that we use a lot when we're researching OCD and thinking about how ERP works in the brain. And the habituation is sort of this natural reduction in anxiety. And so it's this process that happens in the brain where your brain kind of gets used to these feelings of discomfort, and then over time they sort of decrease. So again, thinking about the first time you rode a bike versus maybe a recent time you rode your bike, that anxiety went down over time. Sometimes a good way to think about this is a metaphor of like being in the pool. So if you start to get into a really cold pool, maybe you put your feet in, initially that your feet are going to feel really, really cold. And over time, as you sort of stay in the pool, your feet are going to kind of get used to that feeling. And then maybe you take another step in. So that would be kind of shifting the exposure to a different one. And now you're up to your knees, and now maybe your knees are feeling really cold for a little bit. And over time, they'll sort of get used to that feeling too. And so we think about how the brain deals with these uncomfortable feelings in the same way, that over time, the anxiety naturally reduces as you're sort of staying in the moment or staying with that thing that initially feels scary. And so one thing that we talk about in exposure with response prevention is letting your body do that on its own versus sort of doing things to make the anxiety go down. And we know that this natural reduction in anxiety is something that just happens in the brain, and that when there's compulsions or avoidance or other things involved, this can make it harder for the brain to learn that process. And so exposure really works to help the brain learn this process of habituation. Okay, so I'm going to talk now specifically about how doing exposure can break this cycle. I just go, okay. This is the same cycle we talked about earlier, where there's an obsession followed by a bad feeling, followed by a compulsion. But instead of sort of the last arrow where it continues, this is how ERP breaks this cycle. And so the obsession sort of sets the stage for an exposure to occur. And so we want to choose an activity or a situation that would bring up an obsession or relates to an obsession. And so I'm going to stick with the same example I started with the contamination. And so for somebody with a contamination obsession, maybe touching a doorknob brings up those thoughts and feelings. And so then that's the exposure we're going to go with. And so the obsession is, I'm going to get sick. This doorknob is contaminated. And that's going to bring up these uncomfortable feelings, maybe anxiety, distress, or disgust. And the important thing for exposure, and I'll talk about this again in a little bit, is that we want to experience these feelings at what we call a challenging but manageable level. And so finding this level is really, really important. And so we want to find a level where it's challenging OCD, it's a little bit outside of a person's comfort zone, but it's manageable for them. And so again, I'll talk more about finding that level in a little bit. And so we are going to sort of have a person touch that doorknob, experience those feelings at a challenging but manageable level, and then also resisting engaging in any compulsions or any avoidance that OCD says needs to come next. And so in this example, that could be resisting hand washing or maybe avoiding touching other things when the hands are contaminated. And so after engaging with the doorknob in this way, that habituation occurs. And lots of times, a couple different things can happen in the brain when this happens. So the first is that the brain could learn that when these feelings come up of feeling anxious or distressed or disgusted, that they can handle it. There might be changes in how the brain thinks about the actual obsession. So the beliefs about the obsession might actually change. And the exposure item, so in this case, the doorknob, might not elicit those feelings anymore. So again, that's similar to the bike, right? Where like the bike might have been really scary initially, and now it doesn't really bring up any anxious feelings. Okay. So that is how exposure and response prevention sort of works to break the OCD cycle. But what does it actually look like in practice? And so, like we talked about, it looks like gradually facing situations that make us feel nervous or uncomfortable to help us overcome and manage those fears. The big thing here is that it's gradual. And so, again, finding that challenging but manageable level is really, really important. And so this involves small steps, and it's really important that it is at the person actually doing the exposure's pace. And so that person is the driver of the exposures that they engage in and at what pace. So choosing what exposures they want to work on, choosing the pace that they go at, and really determining what that challenging but manageable level is for them, because we know that that level is going to be really different for different people. And so in this way, the sort of person with symptoms, the person doing the exposure, they are the driver of the treatment. And the therapist sort of serves as a coach or a guide or a cheerleader to help them through that process and to really to guide the process, but to sort of follow their lead. The other thing that we talk about when we're challenging OCD is sort of bossing back OCD or doing the opposite of what it says. And so we know that OCD says a lot of things, it has a lot of thoughts on what people can and can't do, has a lot of rules for people. And so lots of times we think about whether bossing back OCD or doing the opposite of what OCD says is something that might be helpful at a challenging but manageable level. And so, for example, if OCD says you can't touch that doorknob because it's contaminated, we can think about if there's a way to do the opposite of that or to boss back OCD in a way that feels manageable to the person. Practice is another really important part of exposure and response prevention. And this is the idea that the more you do something, the easier it gets. And so going back to times that this comes up in daily life, as we know, the more you do it, the more comfortable it can feel. And then lastly, I just wanted to briefly touch on parent involvement or support person involvement in treatment. And so it can be really, really helpful to have a supportive person who is also sort of aware of what's going on in treatment, at least generally, and can be a support to a person that's going through exposure and response prevention. For kids, this might be really especially relevant, and it might be a parent or a caregiver, but even in adults, I think it can be really helpful to have somebody that is sort of aware of what's going on, and so they can sort of support the person in challenging OCD at home as well as in the therapy room. Okay. So the sort of last tool I wanted to show as an example of how we might do this in a session is the sort of showing how we break down a specific fear or obsession into these challenging but manageable steps. And so this is called a hierarchy, and this example on the screen is for a fear of dogs. And so as you can see at the bottom of this table, this is playing with a dog off leash. And so that's the most difficult item on this level, on this table. And so you'll see there's lots of different examples of exposure tasks on the left column that a person might do in order to challenge this fear. You'll see in the middle, these are the resists. And so these are the things we think about as like the compulsions or the things that OCD is telling a person to do during this situation. And then we always ask for ratings. So this is on the right-hand side. And I think ratings can be really, really helpful. And so we oftentimes ask people to rate their uncomfortable or anxious feelings on a scale from 1 to 10. So 1 being like very calm, this is super easy, really minimal, if any, levels of anxiety, and then 10 being like the maximum amount of anxiety a person would experience. And so this rating sort of helps everybody in the room, whether it's the person with OCD, the therapist, maybe the support person, kind of get on the same page about what that person's experiencing. Because I think from the outside, that can be a really tricky thing to understand, sort of what somebody else is feeling in a given situation. And so these ratings help to kind of get on the same page and help us to determine what is that level of challenging but manageable. And again, that level is going to be different for each person. And so it's not that like a 3 is the level we're aiming for everybody. It sort of is really dependent on the person. And so you'll see that the easiest way to challenge this fear is at the top. And so this person rated this as a 2, and it involves watching videos of puppies. And so that would be the first task that this person would engage in. And then when they're feeling ready, when they're feeling done with that one, they might move to the next one. So having a dog in a different room of the house, and sort of slowly work their way up this ladder. And again, it's the person doing the exposure that will decide sort of when it's time to move to the next step, and even what steps they want to work on. Okay. So we've talked kind of about both frontline interventions, but I also just wanted to talk a little bit about some additional sources of support outside of treatment that can be really helpful. And so this is the International OCD Foundation's website. It's a really, really great website and has lots of great resources. And I just wanted to highlight a couple of resources that they have. So first is that they have links to educational resources and current research. And so if you're interested in finding out more about OCD or learning about kind of what the current research is showing, that can be a great place to do that. They also have resources to help find a therapist that specializes in exposure and response prevention, or OCD. They also have links to find support groups. And so this, if you're just looking to sort of have support from people who have been through similar experiences or have similar experiences as you, that is a great resource on there. And then the last one I wanted to highlight is they have a whole section on academic accommodations. And so we know that academic accommodations can be really helpful for people with OCD in the school setting, in the college setting, in the job setting. There can be accommodations as well. And so they have a really helpful page on how to go through that process and some ideas of kind of where to start for what accommodations are helpful for some people.